how do you witness, the obesity, what is now called an epidemic, in your practice, in your specialty, on a day-to-day, how you see it manifest in orthopedics?
Yeah, I mean, it's something that we battle every day, certainly in our patients, and we see it in a lot of our patients. It'll affect them with lower extremity arthritis, so hip arthritis, knee arthritis, and arthritis of the low back. That's primarily when we're seeing people come in complaining about pain in those joints.
Well, welcome to another episode of Beyond the Scale with Dr. Minera. Appreciate you guys tuning in today. And we have with us Dr. James Ward from Blue Ridge Orthopedics. Dr. Ward is a board-certified orthopedic surgeon who specialized in orthopedic surgery at New York University. He then went on to get a specialization or subspecialty in sports medicine at the University of Pittsburgh by way of a fellowship. And we want to thank you for being here, Dr. Ward. Thank you so much. It's very exciting. I know everybody's going to appreciate what we have to talk about today. As an intro, I just wanted to let everyone know one of the main reasons that I wanted to collaborate with somebody like Dr. Ward is because there's a lot of unspoken issues as they pertain to being overweight and obese. And orthopedic conditions. And so, again, we really appreciate you being here.
Yeah, thanks for having me on.
Absolutely. Absolutely. So I wanted, just we're going to jump right into, the topics. I have a few questions here I wanted to ask you. So for starters, I wanted to know, just to give, the audience a perspective, how do you witness, the obesity, what is now called an epidemic, in your practice, in your specialty, on a day-to-day, how you see it manifest in orthopedics?
Yeah, I mean, it's something that we battle every day, certainly in our patients, and we see it in a lot of our patients. It'll affect them with lower extremity arthritis, so hip arthritis, knee arthritis, and arthritis of the low back. That's primarily when we're seeing people come in complaining about pain in those joints. And the answer for those patients is not always surgery. In fact, that's the last resort we want to consider. But we know that patients who are overweight are going to be at higher risk for developing bad arthritis over the course of time that might need surgical treatment. Mm-hmm. So the key for us is to say, how can we get you active so that you can lose the weight? The challenge then is they hurt. And they say, well, I can't work out, or I have difficulty with certain types of workouts because my hips hurt, my back hurts, my knees hurt, whatever it is, all valid reasons. And so that's when partnering, obviously, with somebody who does obesity medicine is great for us. So say, what kind of medications can we use to help you? What kind of dietary plans? How can we modify your diet? Not necessarily restricting, but how can we modify some of the foods you eat so that you can lose a little weight and slowly increase your activity level that you can continue to lose weight, and we create that positive feedback loop. Mm-hmm.
Yeah, so obviously very, very pertinent. So do you see the majority, I guess, of the osteoarthritis and the joint breakdown, is it inevitably associated to being overweight or obesity, or is it, a percentage of what you
I think it's
see?
A significant percentage. You have your patients who have had a prior injury or prior trauma, so they're at risk for arthritis just based on injury. But I would say after living and working in cities where people tend to be a little more active versus coming out into a suburban setting where people are more sedentary, the patients here tend to have a higher percentage of obesity associated with their arthritis compared to a more active population.
I'm glad you mentioned that, because we were talking about, potentially addressing some of the local data, right? And a lot of it, I think, anecdotally is what I wanted to, more or less hear from you. So this is great. I mean, obviously having done your residency at NYU, right? Big city, Pittsburgh as well, big cities. So there is obviously, also an environmental, demographic, social, cultural type of,
Yes.
difference as well. But again, it goes to back to, being sedentary or just, obviously not having to walk everywhere
Right. You live in the
you
city,
go.
you walk to work. Here, you walk to your car, you drive to work.
Yeah.
And those are the things that are hard for us to manage because at the end of the day, you're tired. The last thing you want to do is exercise. So how do you sneak in exercise during your day? How do you stand up at your desk, walk around your office, things like that?
Right. Right. And so, segueing on that, I had looked into what the biomechanical factors are associated to orthopedic issues and obesity. From a biochemical standpoint, we myself as a bariatric specialist, weight loss specialist, I look at endocrinological, the metabolic, so we see a lot of changes, definitely, increases in inflammation. We've gone as far as actually identifying elevated levels of uric acid, hyperuricemia, as a measure of metabolic dysfunction in a lot of patients. And yes, that can definitely translate into issues with gout and joint pain and whatnot. So we follow the biochemicals, the insulin resistance, the hyperlipidemia, all that. Can you mention, what are some of the biomechanical issues that you see with, obesity and in orthopedics?
Yeah, I mean, you're going to see a lot of the amount of force that you're putting on the joint. It can only withstand so much. And the joints only have such a big surface area to distribute all that force. So if you are overweight or obese, eventually the body is not able to withstand that. And we had talked about, prior to this off camera, there is some data, and some of it is true, to say when you have weight, when you're ascending or descending stairs, that your knees are seeing 5 to 7 times your body weight. So for some of those higher level activities, and going up and down stairs is something that most of us do every day, even little changes in your weight will change the biomechanics of that joint significantly. It's not going to reverse what happened, but we can prevent or reduce the incidence of further damage.
Right.
There's also good studies that show that physical therapy or regular exercise reduces the symptoms associated with especially knee arthritis. And again, it's not fixing the joint, but having a stronger base, stronger core, low back, pelvis, muscles in the legs are going to reduce the symptoms that you feel from the arthritis, even though the x-rays aren't going to change. Right. So those are how the biomechanics, how you distribute your force, not just through the bones themselves.
Right. Yeah, that's an interesting, like you said, off camera, we talked a little bit about that, how much force is placed on a joint by nature of weight. There was a interesting, we all, I think, even not being in medicine, we've always been told that for each pound of body weight lost, that equates to about 4 pounds of pressure off of a joint. We talked about, there is real data supporting that.
And I think that's just a nice way, even if it's not exact, it's a nice way for patients to kind of think about things, that even though the scale might only be moving a little bit, I'm making a big difference in terms of my, the protection of my joints, preventing the need from surgery, basically preventing the need to come in and see us for cortisone injections, which we know are helpful in the short term, but definitely have detrimental effects in the long term.
You bring up a really great point. I'm sure a lot of, our audience is going to be curious about that. They get mixed messages or different, types of recommendations, speaking of, joint injections and whatnot. There's a limitation as to, how many you can perform. Would you mind just commenting on that? What are we looking at? How often can they get them? Is this, a long-term, solution, in addition to obviously, changing the biomechanics and reducing weight and whatnot? Is it just a segue or a bridge to surgery? How do we use that?
Yeah, it's funny because sometimes I'll have patients who come in, they'll say, I was told I can only have 3 in my lifetime. And I don't know where people are getting that from. Obviously, they're either reading it or someone's telling them that. If you have a steroid injection 10 years ago, I'm not going to hold that against you today.
Right.
So that's not the way the metabolism of it works. What we think we know, at least from the kind of biochemical studies that some of these things that we put in there, whether it be the local anesthetic or the steroid, can damage the cartilage. And so we know that more injections more often is bad, as kind of a general catch-all statement. Most people are not going to want to do injections every 3 or 4 months, or every more often than every 3 or 4 months into the same joint. So if you have it into one knee, it doesn't mean it's 3 or 4 months before any other site in their body. Everything is kind of site specific. So I don't really like to do them every more than, say, 3 or 4 times a year, recognizing that if I'm doing them more often, I'm really not helping you that much. I'm probably causing more long-term damage, and I'm pushing you towards the need for surgery. So a lot of times we'll try to use them and say, let me get you to feel a little bit better in the short term with either an injection in this case, or a medication or something like that, as the bridge to say, get out there and get more active. How do we get you to lose the weight? How do we increase your muscle mass so that we're using the other things to make you feel better and not relying on a chemical that's potentially harmful in the long term?
Yeah, absolutely. Thinking about, exercises and whatnot, one of the things that I usually, or I will often get from a lot of my patients is, I wasn't always like this, I wasn't always, overweight. I was an athlete when I was in college, when I was in high school. So it's not, unusual, part of the process, as yours is as well, is, getting a good patient history. I like to know, okay, when did this start for you? Have you always been suffering from being overweight? Is your family overweight? What's the history and whatnot? But I do get that a lot, and they tell me, well, you know what, doc, I can't work out anymore. I can't exercise because my knees are shot. So I guess the idea has always been, I need to run, or I need to do, all these exercises and whatnot. We tell patients, if you overrun, you can end up, hurting your knees. What is your take, your advice, when it comes to working out and exercising? Is there a correlation between, I was a runner in college and that's why my knees are shot now, and now I'm overweight or I'm obese? And what can you, also with your experience, and also, knowing that with Blue Ridge Orthopedics, you guys offer a very, very well-rounded, thorough physical therapy program as well. Thinking outside of the box, it doesn't all have to be running, right? So I guess it's several questions there.
So I'm a runner. I love running. And there's actually really good data. And this was done to marathon runners, so it's a little bit of a specialized population, that showed that they have lower rates of osteoarthritis than the general population. So running in and of itself is not bad for your knees. Being overweight is bad for your knees. So runners tend to be at a healthier weight. Therefore, it's probably protective for them in the long term. But running is a hard sport to get into. One, it takes a lot of time. And when you're overweight, it's going to hurt, and not hurt in a really good way. So for those kind of patients, I would say, let's just start somewhere.
Right.
A lower impact activity program, whether it be an exercise bike, an elliptical, a rowing machine, are great places to start. And if you want to progress to running, if you were formerly a runner, or if that's something you want to do, great. You've kind of gotten the ball rolling. Swimming is the best one from a resistance and protection of the joints standpoint. The problem with swimming is it's an access issue.
Right.
It's hard to get to the pool, and you have to change, and it takes longer rather than going outside your house and just going for a brisk walk. And they'll often cite, try to get 30 minutes of activity a day, but it doesn't always be 30 minutes in a row.
Right.
So getting out there and just doing a little bit is helpful. And the other thing we always want to look at is resistance training, weightlifting. And it doesn't have to be going to the gym and physically lifting weights, but increasing and maintaining muscle mass is really helpful for joint protection. It helps in terms of preventing falls, especially as we get older. That's a big concern for people with osteoporosis and hip fractures. And it helps to increase your metabolic rate, as you well know. So
right.
all those things. So it doesn't always have to be, I have to run 30 miles a week. No, you just have to be active in some form. And you have to like what you're doing too.
Right.
Because if you don't enjoy it, you're not going to do it.
It's not going to last. Yep. Yeah, it has to be some type of motivation. Several thoughts on. I mean, I'm really glad you mentioned a few things. I think one of the things that I always try to tell my patients is it's about getting time, time out there, physical activity. I have a lot of people who are like discouraged because they're like, well, you know what, I was supposed to run a mile and I just couldn't do it. Don't think of it in terms of miles, right? If you're going to do 30 minutes, just say, hey, I'm going to get out there and get 10 minutes done, and then the next 10 minutes and the next 10 minutes. So that cumulative physical activity, very, very important.
Yeah.
Yeah. So that's great. And also, like you were saying, you got to make it enjoyable. Otherwise, it's not going to last. Now, mind you, I mean, not everything in life has to be, pleasurable and enjoyable. But there's got to be some motivation. If you're not enjoying it enough, it's not going to last. If you can enjoy it most times, and then the rest of the time, just be happy that you're getting those health benefits that works out too.
And how do you then sneak in that exercise? Park farther from the office.
Yeah.
You take the stairs. Those little things you have to do. Well, you climb 3-4 flights of stairs. There's a little more activity in your day. You're creating that positive feedback loop that this now becomes a habit. Lose a little weight, feel better about yourself. Now you're going to want to do those things more and more.
Exactly. And that, also, points towards what we were talking about a little bit earlier as well, where we look at how do you increase your metabolism, your body's ability to burn excess calories and fuel. One of them is already innate just by our, what we call our resting energy expenditure, which is, hey, you and I are sitting here and our body has to function. Our heart has to beat. We have to breathe. We burn energy by doing that. Digestion, we don't think about those things. That just happen. The second way is with ADLs. And that's the other thing I always encourage with patients is, listen, not everybody can exercise. Not everybody can work out as a defined, set time with set activity, but you can increase your activities of daily living. Like you were saying, take the stairs if that's feasible for you, park further away if that's feasible for you. When you go to the grocery store, walk around, all the aisles instead of just going in, getting what you need and running back out. So many other ways. And I like to distinguish that, what I like to call exercise versus activity. Activity is movement. You're out there, you're getting, that motion in above and beyond just sitting there breathing. Exercise is a whole separate category, so I know there are a lot of, positive cardiovascular implications to that. But, it's a separate chapter in the book, I would say, So if you can start out with activity, I think that is great. You mentioned, falls in the elderly, and whatnot. And I wanted to, take advantage of that segue also just to mention, if you can tell us a little bit about, what is low trauma injury? How does it affect patients who are markedly or just, slightly overweight or even obese? And how do you, how often or, how common is it in your practice?
Yeah. I think that would divide down into two groups. You're going to have your what we call fragility fractures or fractures related to osteoporosis. And that's just something that happens as we age, we lose bone mass. Women more than men. Men get there. We just get there a little bit later than women. And a simple fall can result in a hip fracture. The scary thing with hip fractures is that the data is that 1 out of 3 hip fracture patients is going to die within a year of that injury if you take all comers over the age of 65,
Wow.
Which is a pretty staggering number. Then that's with surgery. That's with us getting into an operating room within a day or so. They're still at that level of risk. Now, if we don't do surgery, the risk is 80%. And so it's significantly better with surgery, but it's still a real number. And those are typically simple falls. And the things that group of patients can do, again, comes down to maintaining physical strength, because as we age, our reaction time slows. Catch your foot on the rug, you go down. If you have a stronger base, stronger muscles, you're going to be able to withstand that trauma a little bit better. The second group that we're seeing a little more often now that the obesity epidemic has become really in full tilt is the patient who has a younger patient whose BMI is, these are probably patients in excess of 45 or 50 or 55, will have a simple fall. They'll miss a step off a curb. and it'll result in a knee dislocation, which most people think of their kneecapping popping out of place, which is not what this is. This is actually the femur, the thigh bone, and the tibia becoming dissociated from one another. That's typically an injury that we would have seen in a car accident, a motorcycle accident, a fall from several stories. I mean, a high energy trauma. Now we're seeing them from a simple slip and fall. The implications of that could be really severe. That is a limb-threatening injury. As you've damaged all the ligaments, the concern is, did you damage the major blood vessel, the popliteal artery that goes down to the leg? If that's not repaired quickly, you can actually lose the limb, as frightening as that sounds. And in those patients, even if it's not limb-threatening, it requires major surgical reconstruction, months and months, if not a year of therapy to get back to hopefully some semblance of where they were beforehand. And they were already not starting out in the most active state. And that's going to be hard for them.
Yeah. Yeah, that's impressive. So yeah, almost equatable to, somebody, being in a car accident or even hit by a car, where was it not for that one factor of being overweight or obese, it wouldn't be such a damaging injury.
Those types of ultra low velocity knee dislocations, for example, are not something we see in patient population that's of a normal weight, and even patient populations that are in the, say, BMI of 30 to 40. So these are the very overweight patients. So again, if it comes down to, how do I get myself a little bit closer to where I need to be? Those little bit of differences make a huge change for us in the long term in terms of avoiding that injury, and then avoiding all the risks of surgery and the complications that come with it, which are pretty significant.
Right. So you mentioned a very interesting piece of information, data, and I think, again, it's very pertinent, very important to the audience. Why do we see such a high mortality rate after a hip fracture? Like you said, when you intervene, you can lower that risk, but what are the variables at play that make it so significant?
Some of it is just age, which obviously, unfortunately, we cannot control. The other one's that the healthier patients will do better. And so when you look at a patient who comes in with a hip fracture, and again, these are patients who are over the age of 65, they generally have some degree of medical problems that they're coming in with, whether it be hypertension or high blood pressure, high cholesterol, diabetes, and the like. So the patients who are overweight are more likely to have those problems associated. So if you have type 2 diabetes, which is generally what you're going to see associated with the increased weight, higher rates of infection, higher rates of blood clot, higher rates of anesthetic complications, and all of those things after the fact, after the injury and after the surgery, are what result in a problem down the line. And so, again, the patient comes in who's at a healthier weight, lower rates of comorbid or other medical problems, they're going to do better with that surgery. They're also going to be able to mobilize much quicker. Patients who come in who aren't used to physical activity, and now we've added an injury, they're going to have a hard time getting out of bed. They're not going to have the baseline physical strength to carry them through the recovery process. Right.
And we talk in sports medicine. I'm sure that you're very aware of this as well. We talk about muscle mass, but not all muscle mass is created equal to a certain degree, right? We have people who, by nature of being overweight and having to carry a lot of weight, have a large muscle mass structure, but it's not a functional muscle. So one of the focuses we have, during our program here at the center, is that we try to make sure that patients understand it's not just about the muscle, preserving the muscle, but it's also about conditioning that muscle.
Right.
So I'm pretty sure that a lot of patients who are, obese, overweight, although they have that muscle structure, just they don't have that condition that they need to that muscle.
And it's that conditioning to get up and to not put additional strain on your heart, your cardiovascular function. If, again, you're used to exercising or being active, your resting heart rate is going to be a little bit lower. You are able to withstand those changes better as you age.
Right. Perfect. Thank you for answering that. One of the questions I had here for you is, how you and I, ended up collaborating and, speaking to each other about how we could help each other out, when it came to helping patients. And so when a patient is getting ready, to go into surgery, as you alluded to prior, it's very important that they are at their best. We don't want to necessarily replace joints or, do any type of, surgery on patients who are not ideal candidates unless it's emergent. So to get them to an ideal place, especially if they are obese or overweight, I work with a lot of, pre-op orthopedic patients and help them, lose some weight and also improve their metabolic health, because we spoke about biomechanical as well as biochemical, right? So when we look at the operative status, a patient comes in, they're overweight, obese. They need a joint, either replacement or they need some type of intervention on your part. Can you walk us through the process? What kind of conversation do you have with them, and what do you tell them, to look for, and what the reasons for, trying to maximize and pre-op is?
So when that patient comes in to see me, and I do primarily knees and shoulders, or most of my practice. Shoulders are not affected as much by weight, but we'll focus on knees. And they say, I can lose the weight if not for my knee pain. And we've already gone through the non-surgical treatment. We've tried a brace, we've tried therapy, we've tried medications, and the injections just aren't working anymore. And we say, okay, you're now at the point where we say, if we're going to do something, we're talking about a joint replacement. There are pretty clear studies that say if your BMI is over 40, that you are at higher risk of complications from the surgery. And BMI is not always the best marker of health. It has a lot of limitations, but it's very easy for us to measure. And even though it's not historically the greatest measurement, the studies actually bear out that 40 seems to be a number for knee replacements that's important. And so when I have a patient who comes in with a BMI greater than 40, I want to talk to them about saying, how do we get you to a better place? And that's how we started doing a lot of our stuff together, is saying, none of the other things that I'm doing are working. Let's lose some weight. Let's become healthier so I can do the joint replacement. Some clinics won't even address a patient with a BMI over 40. They'll just say, come back to me when you're done. I try to at least work with those patients, say, if you're putting in a good faith effort, I can see that you're trying. I'm as invested in this process as you are. I want you to be successful. So if you're not invested, how is this going to work?
Right.
And so what we see for the patients who are over that range, longer operative times. If the tissue around the joint is bigger, it takes me longer to do the surgery. That increases your rate of infection. That increases the time under anesthesia, which has more complications. And that's just in the short term afterwards. That's just in your first week or two after surgery. Afterwards, when we get into the recovery aspect of it, the strength, the muscle mass around there has to really drive the joint. So if you're getting more swelling because there's more adipose or more fat tissue around the joint, you're not going to be able to get that flexibility back from the knee that you want. And that's an important thing, because we think about our activities of daily living. You need a certain amount of knee flexibility to get out of a car, to get up and down stairs, to ride an exercise bike, which is a great exercise for patients after knee replacement surgery. I really don't want them doing high impact activity. So unfortunately, running at that point, I typically don't recommend. But cycling is great for them. And most people can get either a bike trainer in their house or an exercise bike, something that, or they can go to a gym and have access to. And so the obesity will increase that risk of not getting good strength, good flexibility, and then goes back to that risk of very low velocity injuries. Overweight patient, joint replacement, they fall, they break one of the bones around the joint replacement, and now we're doing another surgery afterwards. And it will never be as good as it was before that. If unfortunately you develop an infection that could lead to several more surgeries, it will never be as good as it should have been. So those are really things we want to protect against.
Absolutely. Yeah. And you mentioned something, really important. It's like, okay, we've tried everything, and I'm not going to operate on you. But, some offices will say, hey, until you come back when you've lost some weight, you know, but what avenues are you offering that patient, to be able to lose the weight? And again, I know there's an endpoint when it comes to, the surgical component of it, but once the surgery is done, and let's say they've lost the weight successfully, then you say, okay, you're a great candidate. Let's get you on the table. Let's replace this joint. Let's talk about, the prosthesis or the joint replacement longevity. What do you see? Obviously, if patients can maintain their weight, the success rate of it lasting for a longer period of time versus, okay, their mentality or their mindset was, let me just lose the weight to get the joint replaced, and then they come back, with overweight again.
Yeah. So if we look at the studies, the current studies on hip and knee replacements, hips do better than knees in general. So a hip replacement will last you between 30 and 35 years if there are no complications, no problems with it. Knee, we're looking at probably about 20 or 25 years. But again, it goes back to that initial thing we were talking about with the biomechanics of it. More force on the joint is going to wear it out faster. It's metal and plastic that we're putting in here. It's very nice metal and plastic, but it's metal and plastic.
Yeah.
And when it's damaged, it has no capacity to heal itself. It's not the human body anymore. It's a prosthesis. And so if you're putting more weight across that joint, your longevity of the joint will diminish. Hard to quantify how much, but it'll be shorter. And we know that revisions of joint replacements, when we have to replace the replacement, much harder surgery, much longer surgery, less predictable outcomes, higher risk of complications. So in an ideal world, we get a patient who says, look, I'm going to put something in you that's going to last for the rest of your life, but you have to treat it well. And that goes back to, I want regular physical activity, low impact at that point, because again, we don't want to put extra strain on the joints. But it doesn't mean that you're limited to just walking. I have patients who go back to skiing afterwards. I just recommend they don't do mobiles or double black diamonds.
Right.
I have patients go back to playing tennis. Just play doubles. And if a patient loves to run, I say, look, if you have a 5K that's near and dear to your heart, it's a charity that you love, go do it. But don't plan on being the 25-mile-a-week runner. But there are ways to still get that activity level, so you're not giving up a whole lot when you get the joint replacement. You just have to shift gears a little bit.
Right. Another question, and this is, something that just kind of like popped into my head as you were speaking. Is there a point where too much is too much when it comes to weight on the joint? Is there a BMI? Is there a certain weight where it's like, okay, you know what, if you go over this threshold, now your knee is getting more pressure than it was designed, to sustain? Or is it dependent on also, the muscle conditioning, or, because I'm pretty sure that, we talked about a lot of these, like bodybuilders, for instance, so bodybuilders are heavy, right? They're heavy. Are they susceptible, to knee joint issues, even though they have, really good muscular structure? Is it more a weight-based thing, weight over time, conditioning situation? I don't know if there's an answer to that, but that'd be interesting. I'm pretty sure people are like, well, I'm okay unless I reach, X, Y, or Z weight. Is there something as easy as that, or is it multifactorial?
It's multifactorial. It's a good question. And I think when you use your analogy of a bodybuilder or an NFL lineman, because that's the one they classically look at, somebody who is overweight but very fit in terms of a lot of strength, they're going to deal with the joint problems better than somebody who has a significant amount of fat tissue versus muscle. And so I think that would be kind of the question, the person who has the resiliency of their muscles, that's going to protect the joint, even though they are at a higher weight, versus a person who's very sedentary. They don't have any of that protective capability of that muscle tissue. So if you're going to choose, if your BMI is elevated, having the muscle mass is going to be better for you.
Right.
And I think that most of our patient population, certainly that we see out here, don't fall into that, I'm overweight because I have so much muscle on me. That's usually higher level athletes. We're not seeing that as routinely in our practices.
Right. And that's that's a great point. One of the fears that a lot of my patients have is based on the scale, number for number, pound by pound. And it's hard to convince some patients, not all of them, to do strength training exercises because they're afraid they're going to get too bulky. They're going to get too big. It's hard to do. Putting on, a certain amount of muscle and in sports medicine. I mean, I know that you're aware of that.
And especially as we get older, I'm dealing with my 20-something-year-old patients. They're very different than my 60-something-year-old patients.
Right.
For men, as your testosterone drops, it's harder to put on muscle later on in life. And so I've very rarely seen somebody who gets too bulky from weight exercise. The other thing we had talked about beforehand, thinking about the scale and not just looking at that number, having a measure of your lean body mass, which we had talked about as a surrogate measurement for, yes, the number isn't changing, but look how much more muscle mass you have compared to your fat mass. That's going to give you good feedback in terms of, I'm doing a lot of good for my body here with resistance training, weight training, things like that.
Exactly. Yeah. And I hope that, that message gets across, definitely, because again, patients walk in our door looking to lose weight. Once I capture them, as I've told them, I'm hoping to help you lose excess unhealthy body fat, but hang on to your lean body mass. So, definitely the paradigm has to shift there. And I hope that message gets across. A question I have to ask you, obviously, because it comes up a lot, is being overweight protective of older patients and their tendency or their inclination to have an osteoporosis? And speaking mostly about women, but you spoke about the lower testosterone in men. That's been associated to brittle bones as well, and osteopenia, and then osteoporosis. But we've heard, and in medical school, and training, again, very general, not as an orthopedist, we've been told, weight is protective of your bones. What's the current, thought?
That is true to a degree, like anything else. So bone is actually a pretty dynamic tissue. It's not just a static thing in our body. It's constantly being broken down and rebuilt. As there's a little micro trauma, micro damage, your body fixes it. When we get to osteoporosis, the rate of breakdown is greater than the rate of building it back up. And so that's the basics of that condition. One of the reasons they think that weight can have some protective effect on that is that bone responds to stress. And if you're putting more stress upon the bone, the body says, hey, I should throw more resources into this. I have to maintain this tissue. And so if it has to carry a heavier load, then it will be stronger.
Makes sense.
And there is validity to that. However, it's not inherently protective against everything. If you are overweight and still have the trauma, now you're at higher risk for all the post-operative complications.
Right.
So I think it comes back to having the increased mass is not bad. It's way better if it's lean muscle mass.
Right.
And that comes down to things. And we had talked about, not everybody can go to the gym and lift weight. In fact, for some of our older patients, they have balance issues. They have other medical conditions that say maybe it's not the safest thing for you to do. Body weight training, resistance bands, things you can do while you're watching TV and a commercial comes on, between the innings of a ball game. Hey, get up and use your resistance bands a little bit. That's going to make a huge difference for them in the long term in terms of protecting their joints, protecting them from falls, protecting them from ending up in the emergency room.
Right. So we get back to the same, general concept. I think we're hitting the same, concept on different angles. Is that definitely muscle is health all around. So.
And there's so much new data coming out supporting that. It's not just losing weight, it's being at a healthier weight.
Right.
So I try to use that phrase a lot more than how do we get you to be healthier, rather than just looking at the scale and saying the number is what I want it to be.
Right. Exactly. Good. But before we close, I'm pretty sure, I have like a million questions, and I'm pretty sure, the audience would have a million questions as well. I mean, I could pick your brain all day. But I didn't want to leave, our conversation without mentioning something that we spoke about before. There was a study came out in the New England Journal of Medicine in October of 2024, at the end of last year. And as the the injectables, the GLP-1s are becoming much more mainstream. Everyone's talking about them. It's everybody wants to have their shot. To help them lose weight. It's important to kind of like talk a little bit about what the conclusion of this study was. One of the side or one of the endpoints studied in this particular article for a GLP-1 was a relief of pain in osteoarthritis and how it was very beneficial. We've seen it beneficial in so many other areas as well, like obstructive sleep apnea. Now it's becoming a secondary indication for that. Prevention, there was a trial came out, it was published some years ago, the SELECT trial, where semaglutide was touted to, or actually was associated with a decrease in secondary stroke and secondary heart attack as well. So we're seeing a lot of benefits kind of trickling from this new medication. So its role in relief of pain in osteoarthritis is something that we were commenting about. I know it's very early on, but any types of comments or thoughts about that?
Yeah, I mean, this group of drugs is turning out, at least with the data we have, to be pretty impressive, the far-reaching effects that it's having in improving people's health. So the easy way to look at how it's going to help the patient with osteoarthritis is if you're at a lower weight or a healthier weight, you're going to have less symptoms associated with it. And that's just the mechanics of the joint itself. But now they're saying, is there something associated with these medications where it reduces the inflammatory markers in our body? And if you have less body inflammation, which is somewhat of a buzzword you see, but it is a real thing, are you feeling less discomfort? Are you feeling less pain? And so I think it's yet another way to say these medications, when properly used, are having far-reaching effects to improve your overall health, not just from the body mass aspect of it, but the body chemistry aspect of it too.
Mm-hmm, mm-hmm. Yeah. So going back to the original, how we started the whole conversation, your biomechanical and your biochemical. Right. So yeah, I mean, I think a lot of exciting things coming down, definitely the pipe, with a lot of the medications, a lot of these secondary endpoints, and we're very excited to be part of it. So I want to thank you very much for joining me today. I mean, this has been a great conversation. Like I said, probably going to generate a lot of buzz, a lot of questions, a lot more. And we're very hopeful that you'll be able to join us again when we have, a whole set of new questions. So
would love to do it.
Thank you very much. Thank you very much. So on behalf of us, want to, thank you for being here. And I want to thank the audience also for being a part of this podcast. Please continue to tune in. We're going to have some more topics as we move forward. And we're hoping that you can join us for the next episode. So thank you so much. We appreciate your time.